Hello, everyone. Today we're going to be covering Chapter 6 in your mammography review book titled Breast Imaging Mammography. All right, so the importance of mammography. Well, of course, we want to try to detect lesions under 2 millimeters. Mammography is very, very sensitive when it comes to evaluating any type of malignant or benign lesion within the breast tissue. It's relatively safe, which is why they recommend yearly screening imaging. It is non invasive and it is cost effective. So, some of the factors affecting image quality in mammography. So, with digital mammography, the inherent quality of the mammography unit, meaning that as a mammography machine ages, of course, the overall image quality is going to decrease. Processing conditions. How well informed the technologists are. Do they know how to use all of the post processing functions on the machines? Compression can affect image quality. Of course, if we do not compress enough of the breast tissue, that breast tissue will continue to overlap, which can actually show up as some type of potential suspicious lesion, which is why adequate compression is so important. And then lastly, patient positioning. If we do not position our patients correctly, if we do not visualize enough breast tissue, they will ultimately have to come back and get repeat images. So, factors that affect interpretation. So, overall image quality, the patient position based on the technologist's skills. Also, the level of skill and ability of the radiologist, their overall skill with comparison assessment, comparing previous mammograms to the mammogram that the patient gets that day. Also, diagnostic workups as needed. And the use of adjunctive modality imaging is based on standard guidelines, meaning that, if they see a lesion on the mammogram, will they refer them to MRI, refer them to ultrasound? Will they get additional views on the mammogram machine? It all depends on the radiologist's report. Breast compression. So the breast should be compressed until it is considered taut. Taut means that as you're compressing the breast, if you were to take your finger on the lateral border of the breast and kind of tap the skin, it should not dimple in. That is the definition of taut. So, the reasons for breast compression in mammography is that it allows for uniform breast density by reducing the tissue thickness evenly. It also helps to reduce the radiation dose to the breast. It brings breast lesions closer to the detector so that we can evaluate them with greater quality. It reduces the possibility of motion, especially when patients are trying to breathe. It increases the contrast by reducing scattered radiation. And then lastly, it separates the superimposed areas so that we can see any type of lesion free of superimposition. So, the margins of the breast. To maximize the area under compression, you want to take advantage of the breast's mobility. You want to avoid compression against a fixed margin or tissue. So, the most movable margins are going to be the lateral borders and the inferior borders, where the fixed margins of the breast are going to be the medial aspect closest to the cleavage and the superior aspect closest to your clavicles. So, the initial compression to the final compression. You want to compress the breast gently using automatic compression with your foot pedal slowly. You want to apply the final compression using the manual compression mode, which is going to be the turn dial on your machine. And you want to do that until the skin is taut. You want to be alert for verbal and auditory clues from the patients to kind of indicate their overall comfort level. And, once again, you just want to walk them through this process. You want to let them know exactly what you're doing. You're going to feel some pressure. It might be a little uncomfortable, but let me know if it's unbearable. Any type of terminology like that, just to help you kind of gauge their overall comfort. You want to avoid giving them a painful mammogram. So, once again, communication is important. You want to make sure that the patient is as relaxed as possible. You can use the use of pain medication, so OTC tablets or prescription gels can be used. Where I worked in mammography, we did not typically use pain medications, but know that it may be a possibility depending on where you work. Planned scheduling is also important. So, when you want to schedule the mammogram when the breasts are the least tender. So, if a woman still has a menstrual cycle, you would want to try to avoid doing her mammogram during her menstrual cycle to give her the most comfortable experience possible. And the patient is going to assume control only under certain conditions, meaning that you want to work with them, you want to well inform them of what you're going to do, and make sure that they are as comfortable as possible. And then lastly, you would want your patient to avoid caffeine. It's not recommended as it can make the breast tissue more sensitive. So, the for projection routine imaging. So, for every patient who undergoes a screening mammogram, they are going to get four projections, two projections of each breast, and those are going to include the CC and MLO. Now, CC stands for craniocaudal, meaning that the tube is going to be on the cranial end of the breast, projecting through the caudal aspect. And then you have your MLO, which is your medial lateral oblique. This is going to be where the tube is going to enter in the medial side of the breast and exit on the lateral border. So the complementary projections are considered your CC and MLO. The whole purpose of these projections is to eliminate tissue on one projection does not necessarily eliminate the area from the study, meaning that both projections are not going to include all of the tissue that you need. So for example, on your CC, you can kind of notice that we miss a little bit of this lateral axilla tissue kind of going into your axillary tail. So the reason that we do our MLO is to include that kind of border of tissue. So both of these are considered complementary views because without one, you don't see all of the breast tissue. They complement each other for a comprehensive study. So, making the exposure. The exposure is going to be made on suspended respiration. You want to avoid telling the patient to take a deep breath before the exposure because sometimes they can actually pull their breast posteriorly a little bit out of the compression device. So, you want to just simply say, please don't breathe, don't move. Okay, so now we're going to talk about the craniocaudal or CC projection. The beam is going to travel from the superior aspect to the inferior, and in this view, we are going to visualize the anterior, central, medial, and posterior medial portions of the breast. This projection is poor at visualizing the lateral breast, which is why we complete the MLO projection. So in this example, this is just showing you how the compression device is going to compress moving from the superior aspect to the inferior aspect of the breast. And your resultant image is going to look like this. So this is the medial aspect, this is the lateral aspect of the breast, and then your nipple is in profile. So the detector is going to be horizontal to the patient. The patient is going to face the unit, standing slightly away, and you want them to bend forward onto your detector. The technologist is going to stand on the medial side of the patient, and you want to focus your attention on the medial tissue inclusion, meaning that you want to bring in as much of that medial breast as you possibly can, because you already know that you're going to get a majority of your lateral breast tissue on the MLO. So, placement of the arms and the head. The patient's arm is going to be closest to the breast being examined, and that's going to be by the patient's side. Now, the contralateral arm is going to be raised and holding the machine for support. There's always a little handle that the patient can hold on to. Now, the patient's head is going to be turned opposite to the side being imaged. So, for example, if you were imaging the right breast, like this patient is, her head is going to be facing you on the medial side or facing her left breast. Then you want to make sure you have an elevated IMF or intramammary fold. So you want to position the breast in the center of the detector. You're going to use both hands to firmly lift the breast up and away from the chest. You want it to be almost parallel with the ground or perpendicular to the machine. The left breast, to the extent of its natural mobility, you are going to move it out of the way. That you're going to position the detector at the level of the raised IMF or intramammary crease. So correct IMP placement. You want to place the posterior nipple line or the PNL parallel to the detector and perpendicular to the X-ray beam. If the detector is too high, you're going to have a loss of inferior and posterior tissue. Whereas if the detector is too low, you're going to have a loss of superior and posterior tissue. Okay, so you want to bring that IMF up nice and high. Make sure that your posterior nipple line is parallel to the imaging plate or perpendicular to your imaging beam. You want to avoid the bone and the skin folds. So, to minimize painful compression of the sternum, you want to pull the skin on the chest wall over the clavicle before the compression begins. And this is going to decrease skin tension. So, basically, this technologist, she's using her right hand to lift the tissue kind of slightly above the clavicle so that as this compression device comes down, it's not pulling on this immobile skin here. This will help to firmly anchor the breast in place. You want to smooth the skin and avoid skin folds as much as possible. With your hand on the patient's back, you're going to help prevent backward motion of the patient, and you want to externally rotate the humerus to minimize skin folds. This area of the breast, kind of right up underneath the axilla, is the most common area for skin folds. Then you do not want to rotate the patient because you want to make sure that you include all of that medial tissue. And then you're going to hold the breast as the compression begins, kind of helping to smooth out the folds. To maximize medial tissue inclusion, you want to pull the lateral tissue forward onto the detector before compression is complete. That mobile lateral tissue can be pulled in as much as 2 centimeters onto the detector. However, you do not want to sacrifice your medial breast tissue, as that is the whole purpose of the CC, is to include that medial breast tissue. If you need to, you can perform an XCCL projection if the lateral tissue is not completely visualized. Meaning, if they have a very, very dense fibroglandular axillary tail, you can complete an XCCL projection, especially if it's like their first mammogram, to make sure that you include all of that lateral tissue as well. And that's going to depend on your department protocol. Okay, so minimize tissue overlap. You want to drape the contralateral breast over the edge of the detector to maximize medial tissue visualization. You want to make sure that there is no overlapping tissue in the cleavage area. And then you are going to begin compression while supporting the breast. So the key point for the CC, the detector is going to be positioned at the inframammary crease of the elevated breast and the patient's head away from the side being examined. The patient's arm closest to the breast being examined by the patient's side, and the other arm is going to be raised and holding the machine for support. And then you want to make sure that you take the exposure on arrested respiration. Try to stay away from having them take in a deep breath, as they can kind of pull their breast tissue away from the machine. So the optimal CC is going to have a P&L within 1 centimeter of MLO if pectoral muscle is not imaged. You should see the lateral extension of glandular tissue included. If it is not, then you can do an XCCL to include kind of that lateral axillary tail region. The pectoral muscle is not always seen on your CC projection, which is depicted right here. It's typically only seen on 20 to 30% of CC images. You should see the nipple centered to the image receptor. You want to make sure that you include the cleavage, which shows that you included all of the medial tissue. You should be able to see minimal skin folds, and dense areas are well penetrated. So for posterior nipple line on the CC projection, the P&L should extend from the nipple to the posterior edge of the image. If the nipple is not centered, the nipple is usually going to point in the direction of missing tissue. So if the nipple is not directly centered to your board, it will literally point to the side that you are clipping. So for example, if you're not including adequate lateral tissue, you will see that the nipple should be pointing more towards the lateral side of the breast. And we want to make sure that we image the nipple in profile, okay? So um sometimes the nipple will not image in profile. For example, in this image, you can see that the nipple is kind of pointing in a superior aspect. You would want to make sure that you either raise that image detector or lower it to get that nipple in profile, because you do not want the doctor to mistake the nipple for some type of subareolar lesion. So if the nipple is not in profile, here are some corrections you can make. You can release the compression device and reposition. You also want to use nipple markers. So, the use of nipple markers is going to tell the doctor where the nipple is on every projection. Where I worked, this was a requirement for every patient, but that may change depending on your facility. Now, the superimposed nipple on an anterior breast tissue should or could be mistaken for a lesion, which is why we use those nipple markers. You want to make sure that you do not sacrifice breast tissue to project the nipple in profile, as the nipple in profile only has to be on one projection. So if you're going to end up clipping tissue by getting it in profile, do not sacrifice that breast tissue. Go ahead and just make sure it's in profile on your other projection. All right, so now we're going to move on to our MLO projection, or our second complementary view. So for the MLO, the beam is going to be directed superior medial to inferior lateral. And this projection is going to visualize the extreme posterior and upper outer quadrant of the breast. This projection is poor at visualizing anterior, central, and medial breast tissue, which is why we complete the CC projection. So when positioning the MLO, you want to make sure that you first locate the mid-axillary line. The angle of the mid-axillary line will determine the tube angulation. Typically, we position the tube at 45 degrees, and then you can kind of move it from there, either, more of an angle or less of an angle based on their mid-axillary line. And then you want to position the breast anterior to the detector. So the lateral aspect of the breast is going to be the side of the breast that is touching your image receptor. So tube angulation is going to depend on body habitus. Tall and thin patients are going to require a steeper angulation, typically anywhere from 50 to 60, whereas the average patient is going to be anywhere from 40 to 50. I generally started at 45 and then would adjust accordingly. Shorter and stockier patients are going to have a shallow angulation at around 30 to 40 degrees. And you want to position the detector level with the apex of the axilla. So the very uppermost border of your image receptor is going to be at the apex of the axilla. And you want to make sure that you avoid air gaps. So you want to drape the ipsilateral arm over the top of the detector, and you're going to turn the patient's feet to the detector so that they are facing it. The patient's elbow is going to be bent slightly, as seen here, and the patient's hand should rest on but not grip the handle of the detector. If they grip, you're going to see a very, very tense pectoral muscle. It's much easier to position if they are more so just resting on the handle versus gripping it. The detector should fit tight against the mid-axillary line without any air gaps. And then the hand behind the patient will stop the patient from pulling back. You want to make sure that you support the anterior breast, so you do not release the anterior breast until the compression paddle releases your hand. You want to use your fingers to open the IF before completing compression. So remember that your IF is going to be this little fold. You want to make sure that your hand is kind of compressing that breast and opening it up that IF before you complete your full compression. And you want to avoid compressing bone. The biggest thing that people will end up compressing is part of the clavicle. So know that the compression device should be directly anterior to the clavicle and just inferior to the humeral head. You want to adjust the skin over the sternum and clavicle to avoid pulling. And the patient is going to hold the contralateral breast if needed, but you want to avoid imaging the patient's knuckles. So as the patient is holding this breast out of the way, you want to make sure that their knuckles are not going to be anywhere over this little paddle right here. So the key points for the MLO, you're going to have a tube angulation that will vary between 30 and 70 degrees depending on your patient's size, because you want that detector to be parallel with your pectoral muscle. The arm closest to the breast being imaged is going to be draped over the top of the detector and resting on the hand holder. The detector is going to be in the armpit, and compression must support the anterior breast tissue to prevent sagging and distortion of ductal architecture. And the pectoral muscle should be demonstrated to the level of the nipple. If you do not see pectoral muscle directly posterior to your P&L, then you did not include enough of your breast tissue on that MLO. So, an optimal MLO is going to include pectoral muscle, convex anterior border, wide superiorly, gradually narrows inferiorly into the nipple line or below. Meaning that if you find where your nipple is and you draw a line directly posterior from the nipple, it should intersect pectoral muscle. If it doesn't, it means that you did not pull enough of that muscle in to your image receptor. This ensures that you included posterior tissue. You should also be able to see retroglandular fat space. You should see an open IMF, meaning that you'll see this nice little border down here at the distal end of the breast. You should be able to see the nipple in profile when possible. And then you want to see dense areas of the breast tissue well penetrated. So this is an example of what I was just talking about with the pectoral muscle. So on image A, if we draw a line posterior to the nipple, we can see nice pectoral muscle. As compared to image B, if we trace this all the way back, we do not see pectoral muscle, which means that they did not pull enough of this breast into the machine, so it needs to be repeated. Okay, and then also suboptimal, you should see a nice wide pectoral muscle kind of convex down your image. If you see it kind of straight like this, you don't necessarily need to repeat it, but it's suboptimal. And then same thing with image D, this kind of concave appearance. This isn't repeatable as long as you can see it posterior to the nipple line, but of course it would not be optimal. Okay, so the posterior nipple line on your MLO projection. Once again, from the nipple to the pectoralis muscle or the posterior edge of the image, whichever comes first. Meaning that if you draw a line directly posterior from your nipple, it should intersect muscle. If it doesn't, you want to go ahead and repeat that image and try to pull in more of their breast tissue. You also want to avoid the droop anterior breast. When I went to mammography school, they always called it the Snoopy breast. So you want to make sure that you use adequate compression and that you do not see a droopiness of the breast. So, for example, on this image, you can see that the breast is kind of drooping down. You can tell that they didn't get very good compression because the tissue is very, very dense. So, just like with your CC, you want to lift that breast up to a 90-degree angle if possible. And then as you compress, don't let go until the breast starts to stay in place. Because as soon as it starts to droop, you're not going to get adequate compression. Okay, so then MQSA required identification for images. First, the image must include the name of the patient plus additional patient identifiers, such as the birthday, whatever your facility protocol is. It must also include the date of the examination, so the date that the patient was seen. It should also say the projection and laterality placed near the axilla, meaning is it an RCC indicating that it's the right breast CC projection, or is it the LMLO meaning it's the left breast and the MLO projection? It should also say the facility's name and address. It should say the mammographer's identification, so typically your initials, just like you would use an x ray. We do not use physical letter markers, so you will just log in under your account, and that is what will notate your images. Also, cassette and screen identification if needed. However, in the world of digital mammography, this is obsolete. And then the mammography unit identification if more than one unit is used. So before signing off, the positioning, a cancer will not be diagnosed if it's not visualized. So that is why patient positioning is so, so important. Also, compression, it's necessary for uniform density. Exposure, we want to make sure that we get adequate penetration of dense areas, especially in younger women with a lot of glandular tissue. Also, good contrast. This is needed to differentiate subtle densities. Sharpness, loss of fine details. We want to be able to see the breast tissue in great detail and with a level of sharpness. Also, artifacts. These should not compromise the interpretation of the mammogram. So, for example, if you got the patient's hand in the image, you would want to repeat that image as that is an artifact. Then we have collimation to the detector. You want to make sure that you're not, using a large paddle for a patient who can fit on a small paddle. And then lastly, labeling. You need to have a standardized labeling process to ensure that you're always complying with MQSA standards. Okay, so now we are going to talk about the supplementary projections that we perform in mammography. Okay, so why is the need for supplementary projections needed? Well, standard projections are inadequate, especially if there's a suspicious area seen on only one projection. Suspicious areas need workups to avoid the trauma of surgery. Okay, so these supplementary projections really come into play when, say, the radiologist sees something suspicious on the CC, but doesn't necessarily see a correlation on the MLO. So, some of the supplementary projections and positions that we are going to talk about will be the 90-degree medial lateral or ML projection. We're going to also talk about the lateral medial, which is LM, the lateral medial oblique, which is our LMO. We're going to talk about tangential views, the exaggerated craniocaudal laterals or XCCL. Those are very commonly performed. We're going to talk about exaggerated craniocaudal medial projections, so it's just the opposite of your XCCL. We're going to discuss the from below or FB projections, cleavage projections, axillary tail, superior to inferior oblique. We're going to talk about our rolled positions, which can be rolled medial, rolled lateral, rolled superior, and rolled inferior. And then lastly, magnification and spot compression views. Okay, so first we're going to discuss our 90-degree medial lateral or ML projection. This is going to be used to localize a lesion, for example, during a needle localization. This is going to prove that calcifications are benign. So for example, medial lesions are going to be up on the lateral from their position on the MLO, whereas lateral lesions are going to appear down from their projection on the MLO. And then lastly, central lesions are going to show no change within the breast. So for ML imaging, note that the ML should not be used to replace the MLO. Okay, so you never would just do an ML. This would be a supplementary view, which you would do in conjunction with your standard for projection mammogram. And then it doesn't really discuss it, but just to note, the tube side is going to be on the medial aspect of the breast. The lateral side of the breast is going to be against the image receptor, and it is basically an MLO, except that your detector is at a true 90 rather than that tube angulation oblique. Then that brings us to lateral medial or the LM projection, which is just exactly opposite of the one we just spoke about. So this is going to help with details on medial lesions, and it's used to locate an inferior and or lateral lesion, and it can be used for non-conforming patients who may have difficulty with other positions. So basically the medial aspect of the breast is going to be rested against your image receptor. The arm of the breast being visualized is going to be placed on top of the image receptor, and then the compression device is going to compress from the lateral border to the medial border of the breast. So for LM imaging, this can replace the LMO to image a missed area. Okay, typically the LM projections are not that commonly used unless you really have a patient who it's difficult to position for a different view. But these are not as common as the other ones we're going to discuss. Okay, that brings us to the lateral medial oblique, which is directly opposite of our MLO. Okay, so instead of projecting the breast from medial to lateral orientation, we are now orientating the breast in a lateral to medial orientation. So this is useful for imaging medial lesions and also useful for imaging non-conforming patients who may have pacemakers or any type of chest surgery. So the LMO imaging, the LMO is going to give a true reverse of the MLO, and imaging should look exactly the same. So once again, you have your pectoral muscle coming down. You should be able to draw a line from the nipple posteriorly and have it intersect with the muscle. And then the only other thing that you may see missing a little bit is just kind of this inferior posterior aspect of the breast is somewhat limited on this projection. Then we have our tangential projection. So this is when the X-ray beam should just skim the skin surface. This projection is used primarily when the doctor is trying to rule out if something is actually inside of the breast or on the surface of the breast. And basically, for example, say this was the lesion that they were looking at, you compress the breast in a way that the X-ray beam is just going to skim that outside surface. Okay, so a little bit different than a spot compression view. As notated in this image, the central ray is going to barely skim the external surface of whatever orientation of the breast that you are looking at. The tangential can be used in any projection or orientation, and it's used to locate skin calcifications or lesions. So, for example, this is a tangential image of the cleavage. So, they're looking at these calcifications, trying to determine are they in the skin or are they, deep within the breast tissue. Then we have our XCCL, or our exaggerated craniocaudal view. This is a very, very common view, and it's used to show the lateral aspect of the breast that is not seen on the CC projection. In layman's terms, this image is basically a CC, except that you're pulling in as much lateral tissue as possible, and you're going to clip a little bit of medial. So for added imaging needed, for example, in this image, if you guys look at the left breast, you can see that the axillary tail, you can see it quite well. And you can see this retromammary fat behind that glandular tissue. So in this case, no XCCL would be required because the glandular tissue ends before the chest wall edge of the image. Whereas if you compare it to this mammogram over here, you can tell that they have quite a bit of posterior glandular tissue that we're not visualizing on that lateral side. So this is when you would want to use an XCCL projection to ensure that you're visualizing all of that lateral tissue. Then we have what's called an XCCM, or exaggerated conio medial. So this is going to be used to show the medial aspect of the breast not seen on the CC projection. So similar to what we were just talking about, for example, the medial aspect of this breast you can see just fine. So you wouldn't need that projection. However, if it looked like this on the medial side of the breast, that is when that XCCM projection would be indicated because you're clipping that medial glandular tissue. Then that brings us to the craniocaudal, or from below projection. So this is going to be used to visualize lesions in the superior or upper quadrants of the breast. And it's basically our CC projection. However, it's flip-flopped. So our image detector is going to be at the superior aspect of the breast, and the paddle is going to be coming from up underneath, or the inferior aspect of the breast. So from below imaging is useful for imaging the small breast. It can also be used for kyphotic patients who might otherwise have their shoulders be projected onto the CC view. And it can also be used for patients with pacemakers so that you're not pulling on that skin tissue right around their pacemaker. Then we have our cleavage, or our valley view, or CV view as it's abbreviated. And this is going to image the medial breast tissue for both sides. So basically, it's similar to a CC view, except that you bring in both breasts to the imaging plate, and you just focus on separating the breast tissue so that you can see the cleavage in good detail. Okay, for this one, you do not care about the lateral aspect, so it's okay that their breast tissue might, be out of the field of view on the lateral side because we're just concerned about this valley area. Then we have our axillary tail view, which is going to be used to visualize the tail of the breast. It's kind of similar to the lateral medial projection, except we're going to center higher up in the breast and really focus right underneath that axillary region. So the axillary tail imaging, the degree of angulation is going to be based on the radiologist's preference. Some prefer a 20-degree tube rotation, whereas others may require no tube rotation. The axillary tail should not include the inferior portion of the breast. So once again, it's just like your lateral medial or medial lateral projection, except that you're only focused on this kind of axillary region. So you get the corner of your image receptor way up in the apex of their axilla, and you just compress the axillary tail portion of the breast. This is primarily used for if they're trying to look at an enlarged lymph node that may look a little suspicious, anything like that. Then we have our superior to inferior oblique, or SIO projection. This is going to demonstrate the upper, inner, and the lower outer quadrant of the breast. This is useful when imaging implants and to get an open inframammary fold. Okay. This one is not as common. Personally, I've never performed this projection, but basically, it's like a reverse MLO in that the patient, instead of facing the tube, is going to actually face the image receptor, and you are going to compress the breast from the lateral region, um, compressing the breast, the medial breast, against the image receptor. And an SIO image is going to look similar to this. So the beam is directed from the superior lateral aspect of the breast to the inferior medial aspect of the breast. You're not going to see as much pectoral muscle as you would on, say, an MLO, but you will see a more uniform compression of that inferior medial aspect of the breast tissue. Then we have our rolled positions. So this is going to be used when we're trying to remove superimposed tissues. These projections are not as common anymore with the invention of tomosynthesis, because tomo kind of is giving us a rolled position type analysis of the breast. However, if you're at a facility that does not have tomo, then you may have to do rolled positions from time to time. So if you're doing a CC projection, you can either roll the breast medially or roll it laterally, meaning that you are literally putting your hand on top and on the bottom of the breast, and you are rolling it in opposite directions. And then the same goes for the lateral. If you're in a lateral projection, you can either roll the breast superiorly or roll it inferiorly towards the ground. So for the rolled medial projection, when you're in the CC position, the portion of the breast away from the detector is rolled medially and the lower position is moved laterally. Okay, so basically your upper hand is going to roll the breast medially, whereas the hand on the bottom is going to roll the breast laterally. And this is going to help remove those superimposed structures so that we can actually see if a lesion is real or not. Same with the roll lateral. So for a roll lateral, the upper portion is going to be the portion that is rolled to the lateral side, whereas the inferior portion is going to be rolled medially. Okay, so whenever you hear these terminologies for rolls, whatever roll lateral or roll projection it is, for example, roll lateral, it's always referring to the upper or superior aspect of the breast. That is the direction it moves. And then you know that the opposite side of the breast has to move in the opposite direction. Okay, so rolled lateral, upper side moves lateral, lower side moves medial. Then that brings us to rolled superior. So rolled superior, when you're in the lateral projection, from the lateral position, the portion of the breast away from the detector is rolled superiorly, and the lower portion is rolled inferiorly. So, meaning that the medial aspect of your breast is going to be moved up, and the lateral portion that's touching your image receptor is going to be rolled down or inferiorly. And then the same goes for rolled inferior. So for rolled inferior, the medial side of the breast is moved down, the lateral side is moved up. Okay, so when you're talking about medial or lateral, that is going to indicate the superior aspect of the breast. When you're talking about a rolled superior or rolled inferior, you're referring to the medial aspect of the breast first. Then we have magnification. So magnification views are very commonly used, especially for diagnostic reasons. They're used to analyze calcifications and then also evaluate margins of lesions. Magnification use does increase patient dose, so that is why accurate patient positioning is imperative. So for magnification imaging, for example, on this MLO, we can see that there's an area of calcifications that they may be concerned about. It's kind of hard to tell in detail what those look like. So we do a magnification view, and then of course you can see them. Radiolucent center, probably not as concerning. They're kind of scattered, but they can see them in greater detail. And then we have what's called spot compression views. Spot compression views can be used to evaluate suspicious areas. They can also be used to evaluate microcalcifications similar to magnification. Oftentimes, they will they will have you do a magnification and spot compression view combined. The focused compression will spread out and away the overlapping tissue, and the spot can be performed in any projection with or without magnification. It just depends on what they're looking at. Okay, so for example, on your standard CC projection, you have these three lesions that are kind of superimposing one another. When you do a spot compression image, you are going to compress just that area of the breast, which helps to decrease OID, and it spreads out those lesions so that you can see each of them in better detail. So, a spot compression is used for localization of suspected abnormalities. With spot compression, more compression is applied to a localized area of interest using a smaller compression plate. So, here's our actual compression paddle, and here's the lesion that we're trying to look at in greater detail. Then we have the augmented breast. So remember that a patient can either have silicone implants or saline implants. The methods for those in the early 1920s, we did a direct injection of silicone through needles and vials of liquid silicone that would harden inside the breast. Nowadays, we do surgical augmentations using subglandular or retromammary placement. We can also place the implant subpectoral or retropectoral depending on patient preference. So, when evaluating silicone and saline implants, know that they will look drastically different. A silicone implant is going to be much more dense. Silicone in general has a higher atomic number than saline, which is why it appears so much brighter. Whereas a saline implant is going to look similar to like a water balloon. You're going to see crevices of the encapsulated borders, and it's a little bit more radiolucent as compared to silicone. This is an example of a direct silicone injection. This technique is not available in the United States and is not recommended for use. The reason is because this silicone is going to harden over time. It's going to obscure the amount of breast tissue that you can accurately visualize. And then typically these patients will present with palpable lumps and things like that, which are typically just the result of that silicone kind of bubbling inside in different pockets of the tissue. So, some of the factors affecting the mobility and compression of implant patients is going to be the type of implant. So, is it saline versus silicone? The placement of the implant is going to play a role. The degree of scarring from their surgery, the encapsulation or adhesion of the implant to the chest wall. So, has it kind of attached to the chest wall or is it somewhat mobile? The breast size and amount of actual tissue can make imaging breast implants a little challenging. And then, of course, the emotion of the patient. Typically, they're scared, they're worried that you can pop their implant, things like that, or they could be concerned that their implant is leaking. So this is an example of subglandular versus subpectoral. Okay, so subglandular means that it's going to be placed anteriorly to the pectoral muscle, but behind the breast tissue, whereas a subpectoral implant is going to be placed posteriorly to the pectoralis muscle. Okay, and there's a variety of reasons why a patient would choose one over the other. Then we have surgical incisions. So incisions used to place implants. Typically, you can either see an incision transaxillarly, meaning that they placed it through the axilla region. You can see periareolar, which is fairly common, meaning that they excise basically the inferior border of the areola. And then also inframammary, where they actually go in kind of near the inframammary fold, and then that is where they place the implant. So when you're doing a mammogram on an implant patient, you want to make sure that you mark where their surgical scars are. Then you have tissue expansion. So this is going to use to expand the area needed for implant placement. Okay, basically they expand the tissue, make it more elastic so that the implant can fit once they're done with the surgery. So when you're imaging implant patients, you're going to do the routine 4 projection MLO and CC with limited compression, and then you're going to do 4 implant displace series with maximum compression using the MLO and CC projections as well. So anytime you're imaging an implant patient, you're going to do double the amount of images, so 8 images total. So limited compression series. You're going to do your standard CC and MLO with minimal compression to demonstrate the margins of the implant. And you want to make sure that you use a manual technique to image through that dense implant. So with this one, you're going to position like normal, but you're going to use just minimal compression so that the breast doesn't move. And it's a way for the doctor to evaluate the contours of the implant, make sure they're not leaking, anything like that. After you complete those projections, then you're going to move on to the implant displaced projections, which are going to demonstrate the actual breast tissue. So for these ones, you can either use a manual or AEC technique, and you want to make sure that the breast covers the portion of the detector when you're using AEC. So when you're imaging implants, you want to feel for the margins of the implant. You want to have the patient step away from the unit and then lean forward. You're going to use the detector and the compression plate to keep the implant posteriorly. So typically you want to start at the nipple end with both of your hands, and you're going to kind of pinch, moving back posteriorly until you feel the resistance of that implant. Once you feel the resistance of the implant, then you know that you have all of the anterior breast tissue. You're going to pull that breast tissue onto your imaging plate and just compress the anterior tissue. So once again, you want to locate the extent of the implant, have the patient step away from the unit so that you can feel for where the implant is, place the detector just posterior to the edge of the implant, and use a thumb and finger to hold the anterior breast. As you are compressing, make sure you have one hand on the breast tissue that you want to hold, and then you can use your other hand to kind of keep pushing back that implant as you compress. Okay, and then wrapping up, the extra projection should demonstrate missed breast tissue to justify the added radiation dose to the patient. So anytime you're using any of these supplementary views, they should only be used to evaluate breast tissue that was missing on your existing mammogram. Okay, and you want to also make sure that you evaluate your patient before taking the first image. Be familiar with all of the supplementary projections that we discussed, and you want to always choose the most suitable projection to complete the study. Now, note that it doesn't hurt to consult your lead mammographer or your radiologist to ensure that you taking this extra image is actually going to help this study, or if it's not needed. If it's not needed, then there's no reason to expose the patient to another mammographic image. Okay, and that is all I have for you guys.